Hello students, welcome to Distinction Learning Platform, and on this platform you find revisions, expansion to difficult topics, you find a lot of stuff. So before we begin our lessons, make sure that you subscribe so that you can be updated with all upcoming videos. To make the story short, let us begin, and don't forget to like the video. Okay, so in this video we are talking about congestive heart failure complication. And remember that you must watch the video about congestive heart failure, pathophysiology, classification, and everything about it. So make sure that you watch it. Okay, so what is just to recap, what is congestive heart failure? So congestive heart failure basically is the heart failing to pump enough blood to meet the board demand. So the heart is just failing to pump enough blood or to pump enough cardiac output to to meet the board's demand. That is what we call congestive heart failure. Remember, there are a lot of classification that we need to talk about, but in this complication, let's just speak the important one, which is based on the what side of the heart affected, which is one of the classification of congestive heart failure, which is right-sided heart failure and also left-sided heart failure, as well as what biventricular heart failure. I remember that we talk about also the high output cardiac failure. High output cardiac failure basically it's not because the heart is not pumping enough blood. Basically it's going to have enough cardiac output, because if you talk about the right-sided heart failure and also the left-sided heart failure, they are going to have low cardiac output. For high output cardiac failure, it's going to have high cardiac output. But the reason why is because of vasodilatory problem that we'll talk about. Okay, now let's begin. So now, what are the complications of that? So we'll start with the complication. We can just further categorize them into two: the complication that can arise because of congestion, and the complication that can arise because of shock, okay, or decrease in perfusion. So what are we saying? So we're saying the first complication that we talk about is increase in the congestion. Okay, so that's the first complication which we talk about. Here, the other complication that we talk about is decrease in perfusion or tissue perfusion. Okay, let's just say perfusion. So we'll talk about this. Okay, two important classification of complication. Okay, let's start with this one. Now, as you can see from this side, let's imagine to say this is the left side of the heart which is affected. So the complication that can arise from this side, and also the clinical features that we're going to talk about from this side, these are just for left-sided heart failure. And from this side, we talk about the right side heart failure. Okay, if it fails, basically, then those are the complication that we are going to see under clinical diagnosis. Okay. Now let's start with the right side now, or the left side, I mean. So this is the left side of the heart. Okay, now it is failing. Remember that failing, it means that it's not producing enough cardiac output like that. Okay, basically due to some problem that we talked about, because maybe if it's diastolic heart failure or systolic heart failure, maybe due to decrease in contraction of myocyte or myocardium, or maybe because of decrease feeding or preload. Due to those causes, a lot of causes, MI, a lot of causes that we talked about, okay, then it's going to decrease the cardiac output. Then there will be backflow of blood into the left ventricle, then left atrium. Then left atrium, it will go back to the pulmonary circulation. So what are we saying? So because the heart is failing to pump blood out of the heart, then blood will start going back. So blood will start if this is the aorta, then blood will start going back to the ventricles. It will start going back like that, okay. If it goes back like that, it will go into the pulmonary circulation. That's why fluid is going to enter there, okay. So here there will be enough fluid, okay. If there is a lot of fluid that is going back into the pulmonary circulation, basically it's causing congestion. Congestion is going to increase what we call hydrostatic pressure within the blood vessels. So if there is increase in the hydrostatic pressure, we are going to use a certain term or certain pressure that we need to be using under diagnosis and treatment. So they use a certain pressure which we call pulmonary capillary wedge pressure. It's the one that they use to diagnose if someone is having pulmonary congestion due to cardiac what problem. So what are we saying? If they say increase in, if there is increase fluid here, basically it's going to cause what? Congestion. And this congestion, we're going to increase the what? It's going to increase the pulmonary capillary what? Weight pressure. Okay, weight pressure. Then it has to be greater than what? For you to say that this condition is coming from what? The cardiac failure, you need to specify it has to be greater than what? 18 millimeter of what? Mercury. If it is less than that, it will be due to what? Other causes apart from what? The heart failure. Okay, maybe it can be ARDS, acute respiratory distress syndrome. It can be a lot of causes apart from what? Cardiac failure. So what are we saying? If it's because of cardiac failure, it has to be what? Greater than what? 18 millimeter of what? Mercury. Okay. Now, if there is increase in the capillary weight pressure there because of this pulmonary congestion, what will happen? This fluid will start what? Going into the what? Interstitial space where there is what? A lot of what? Alveoli. Okay. This fluid will start going into there. Okay. Now, what's going to now do? This fluid will start also going to the what? The alveoli, causing what? Alveolar filling. Then what do we call if the fluid now start moving from the pulmonary circulation into the interstitial space? Sometimes maybe enter into the what? Alveolar. We could call it what? Pulmonary edema. So what's the result due to all these what which we're talking about? The result is what? Pulmonary what? Edema. Pulmonary edema. So this is the result of this congestion. It is what? Pulmonary edema. Okay. Sometimes since also fluid is going to the alveoli, is going to the interstitial space, sometimes they can use what? There is the pleural what? Effusion. Because pleural effusion, this fluid can also leak into the what? Pleural space. So what is the other complication that you can see apart from what? Pulmonary edema? It is what? Pleural effusion. Because this same fluid, it will go into the what? Space, okay, which is which we call the pleural space. So if it goes there, then you are going to say that is what? Pleural effusion. Okay, pleural effusion. So what is the other complication due to this also increasing the hydrostatic pressure? They are causing pulmonary congestion. What is the other one? Also, that congestion is making stasis of blood. Remember that stasis of blood is going to promote what? Microorganism or infection to what is start what dividing and making affecting the what? The lungs. Okay, so there will be what? Pulmonary infection, and what? There will be also inflammation. If there is an infection or congestion there will be an inflammatory response, inflammatory reaction that's going to happen, causing what? Lung injury, which we call what? Pneumonia. So what is the other one? The other one is what? Pneumonia. Okay. I can say also pneumonia and pulmonary what? Infection. So this has a pulmonary infection. Okay, pulmonary infection as well. So a lot of what? Complication that can rise due to what? Congestion in the pulmonary circulation. Now, the important aspect is that now, what can you see? What are the clinical features that you can suspect someone to say, okay, this patient is having what? Pulmonary edema. What are those? So this fluid now, if a patient comes, then they are going to have what? Shortness of what? Breath. Maybe when they are stressed, or maybe they are just doing some what? Ordinary activities. What do we call that? We call it what? Dyspnea. So what can you see? So due to this congestion, then if someone so due to this condition, basically someone is going to have what? Dyspnea. Basically that is what? Shortness of breath, whether at rest or maybe doing some ordinary what? Activity. So we call it what? Dyspnea. Okay. That is what? Dyspnea. That is the first thing that you can see if they come and suspect something like that. Okay. What else? Now, if you ask those people during an exam, you ask that patient to lie flat, okay, then they experience what? Shortness of breath. What do we call that? We call it what? Orthopnea. Okay. If they lie flat, basically, if they lie flat, this fluid is going to what? Spread out like that, okay, into at least a lot of alveoli. Then if it is spreading out like that, basically it's going to cause now shortness of breath while lying what? Flat. That is what we call orthopnea. Let me use a pink marker. We call it what? orthopnea. Very, very important clinical what? Feature that you need to what? Access. Okay. Now again, if you don't ask them at lie flat, remember that if you are asleep, basically you sleep flat as well. During at night, if you experience what shortness of breath while lying flat during at night, what do we call that? We call it PND. It's just one. It's just the same as what orthopnea. Orthopnea is just lying flat during an exam like that. You are lying flat minus sleeping. But if you are asleep, then you feel shortness of breath. What do we call that? We call it PND. Okay. We call it what? PND. Paroxysmal nocturnal what? Dyspnea. Paroxysmal nocturnal dyspnea. That is just shortness of breath when you are what? Asleep. Okay. So those are the clinical features that you can observe. Okay. There is also other clinical features that you can observe due to what? Congestion, pulmonary congestion. Let's say someone develops now what we call acute decompensatory what? Heart failure. Basically, these symptoms that you are saying, shortness of breath, also PND, like they are now becoming similar suddenly in onset. Basically, then you are going to suspect that someone is having what? Developing what? Acute decompensatory what? Heart failure. So what is acute decompensatory heart failure? The heart fails to compensate. Now it is failing abruptly, or it is failing what? Very, very fast. The symptoms are developing so fast. So that is what we call acute what? We call it what? If someone now develops what we call acute decompensatory heart failure. Okay, acute decompensatory heart failure. Now you can see now some scary what? Features. So if someone now develop that, then what can you see? You can see now, you can see hypoxia. Okay. Okay, you expect hypoxia. What is hypoxia? Hypoxia is inadequate oxygenation of what? Blood due to what? Or inadequate oxygenation of what? Tissues due to what? Due to a lot of causes. Okay, due to maybe someone they are not compliant to medication. Okay, they are having arrhythmias. They are having a lot of causes. Maybe they are experiencing like thyrotoxicosis. A lot of causes that can cause someone to develop what? ADHF. Okay, then they are going to have what? Hypoxia as one of the important feature. Okay, then basically this type of heart failure, then it is what is so severe. What else apart from hypoxia? So now they are going to have increase in what? Respiratory what? Rate. Okay, they are going to have increase in the respiratory rate. What else apart from incrementing the respiratory rate? Also, they are going to have increase in the wake of what? Breathing. Okay, wake of breathing, increase in the wake of breathing. Why they start using what? The accessory muscles to start what? To help them to start breathing. Okay, they need to show that now this is now a severe what? Type of heart failure, which is the ADHF. Okay, so that's about that. Okay, now that's about congestion. Okay, that's about congestion. Now let's go to what? Perfusion. Remember that we're talking about from the left side. If you see any of these signs, signs and symptoms, then basically suspect what? Left-sided what? Heart failure. Okay, what else? Now we said earlier on to say complication can also arise due to what? Decrease in what? Tissue perfusion. Okay, decrease in tissue perfusion. Reason why? Remember that. Okay, the heart, basically this is from the left side like that. This is the aorta. Remember that there is low cardiac output. For someone to have this complication or right-sided heart failure, or I mean left-sided heart failure, basically they are going to have what? Low cardiac output. Low cardiac output is not going to meet what? The body's demand. Now, if it's not meeting the body demand, basically, if you talk about the brain, there will be low tissue perfusion to the what? To the brain, and also there will be low tissue perfusion to the what? To the heart, kidneys, and what? But there are some complications that can arise due to that. Okay. Now, what do we call if now the heart is failing? Now it has what? It has low cardiac output and failing to perfuse tissues or organs correctly or efficiently. What do we call that? We call it now, that type of shock is, we call it what? Cardiogenic shock. So basically, if they are going to have what? This low cardiac output, then they are going to develop what we call cardiogenic shock. Cardiogenic what? Shock. Cardiogenic shock. and it's a so severe what and dangerous type of disorder. Okay, this cardiogenic shock. Now, let's say if it's affect the brain, what's going to happen to the brain? They're going to develop what we call encephalopathy. Like what? Encephalopathy. Okay, they are going to develop what we call encephalopathy. Like what? TIA. What is TIA? That is transient ischemic attack, where maybe someone they've got what low tissue perfusion to the brain. Okay, but there will be ischemic attack, but the brain is not what is severely damaged. It can go back to normal. That is TIA. Okay, we'll talk about that in more details in other videos. Okay, what else apart from TIA? There is also CVA, cerebrovascular accident. Then basically that will just affect what? The brain. So if low tissue perfusion affect the brain, they are more likely to develop what is encephalopathy, like what TIA or CVA. Then let's go to the heart. What about the heart itself? So the heart itself is failing and experiencing cardiogenic shock. Then what are the things that are going to be what the result? What are the complications of that? So they are going to develop a lot of things. So let's just say they are going to develop the most important one, which is the myocardial infarction. Maybe a non-STEMI or N-STEMI type of what the MI, myocardial infarction. And from MI, that's why you can see now a lot of what the a lot of complications like arrhythmias, like that ventricular tachyarrhythmias, okay, atrial tachyarrhythmias, AFib, okay, because of what? Myocardial infarction. Most important thing that you need to understand. Okay, now let's go to the kidneys. What about the kidneys? The kidneys, they are also receiving what? There is low tissue perfusion to the kidneys. Remember that we talked about the compensatory mechanism on how the kidneys are involved and also the brain. Remember that under the brain we said it's going to what? It's going to activate the what? Sympathetic outflow, resulting in the what? Production of norepinephrine and epinephrine. That will result in what? Increase in the what? Systemic vascular resistance. And what? Those were what? Normal compensatory mechanism. And also for the kidneys, if they is receiving no tissue, low cardiac, there is low tissue perfusion there, or low PP, then it's going to activate the RAS system. Okay, that system, remember how it did. It's going to vasoconstrict as well. It's going to increase the systemic vascular resistance, and what else? It was increasing the increased production of what? Aldosterone. Now, if there is low tissue perfusion to the kidneys, severe tissue perfusion to the kidneys, what's going to result? We know the famous one is what? AKI, acute kidney injury. Okay, AKI, acute kidney what? Injury. Now, there's a term that they use. If the heart fails and also the kidneys fails due to the what? To the cardiac failure. Okay, what we call that? We call it cardiorenal syndrome. If the heart fails, if the kidneys fails due to the what? Cardiac problem, then that syndrome is called what? Cardiorenal syndrome. But there is also renocardial syndrome. The heart fails due to the what? To the kidney problem. Then you are going to say renocardial syndrome. Now here we are going to have cardiorenal problem because of the heart is failing, the kidneys are going to what? To fail. That's a syndrome that what? That you need to talk about. Okay. What is the last one? The bowel. Under the bowel, if there is the low tissue perfusion to the mesenteric arteries there, okay, it's going to cause something. There will be ischemia to the bowel there, okay. A lot of problem that's going to arise. What do we call that? There is we call it what? Okay, we call it AM. Son of the gun. We call it AMI. Acute mesenteric what? Ischemia. Okay, so there will be ischemia of the bowel. They are due to what? Low tissue perfusion to the what? To the bowel. What is the last part under what? The left-sided heart failure complication. The last one is this one. Okay, as you can see, these are tissues. Remember that tissues are what? Tissues are receiving what? No blood. Okay, there is what? Decreased tissue perfusion here, because of the stroke that we are talking about. Decreased tissue perfusion there because of the stroke that we are talking about. Then these cells, remember that if there is decreased tissue perfusion, okay, remember that in blood there is what? Most important thing, that is oxygen. So if there is no tissue perfusion here, also there's tissues that are going to receive what? Less oxygen. Now, if you remember, if the tissue receives less oxygen, what's going to happen now? The pumps will start failing, the sodium pumps, the pumps that are going to depend on what? ATP. Okay, ATP dependent pump, they are going to fail, leading to what? Necrosis. Others, if the cells try to adapt to that, then it's going to start producing what we call lactic acid. Okay, because they'll start, instead of using electron transport chain to produce energy ATP, then they'll start using what? The other process. It will just depend on glycolysis. Basically, if you look at the glycolysis, the end product will be what? Lactate. Lactate now is going to form what we call lactic acid. Lactic acid is going to increase what? The metabolic what? pH. And if you increase the metabolic pH, what are you going to now have? You're going to have what? Metabolic acidosis. Generally, what I'm talking about is, if you have low tissue perfusion to tissues, you are going to have low oxygen supply to that, leading to what? Metabolic acidosis. So what am I talking about here? So I'm talking about what? Metabolic acidosis. Due to what? Increasing the lactic acid production. Okay? Okay. Now, since we are down this side, now let's go to the what? Right-sided heart failure. Again, remember that the first complication is what? Congestion. Okay, that's the first complication, congestion. So complication due to what? Congestion. Okay. So now let's imagine to say we're talking about now this part. This right-sided heart failure. So this is the right-sided heart failure. Okay. Now, if the heart fails now, if the heart is failing from the right side, remember, due to some certain causes. Okay, maybe there is pulmonary hypertension. There is a pulmonary. Okay, there is pulmonary. They are causing what? The right-sided heart failure. Sometimes they say right-sided heart failure can come about due to what? Left-sided heart failure. That is also the other cause of what? Right-sided heart failure. Okay, due to that, now the heart is failing. Remember that it's failing to pump blood into the what? Pulmonary arteries there. Then there'll be what? Backflow of what? Blood there. So blood will start coming back like that. Okay, blood will start coming back into the what? Right ventricle, then right atrium, then it will start going back into the what? This circulation, the venous circulation. Remember that there is now congestion there. Like here we had increasing the pulmonary capillary weight pressure. Also here we are going to have what? A certain pressure that's going to be increased. Why am I talking about these pressures? Because they are very, very important in the diagnostic procedure. So what's going to happen here? So we call it what? The central venous pressure. What are we saying? So here there is increase in the what? Central venous pressure. CVP. Okay, central venous pressure. What's the normal range for central venous pressure? It ranges from what? Normal, it can start from 6 to 8. Other they say from what? 6 to 10 millimeter of what? Mercury. So that's a normal range for central venous pressure. Now remember that if there's backflow of that blood, then basically it's going to increase the what? The central venous pressure. If there's this decrease in the central venous pressure due to what? Congestion there, then blood will start going into the what? The venous circulation. It will go into the what? The jugular vein, causing what? The first clinical feature, which we call distended what? Jugular venous what? There will be what? Jugular venous what? Distension. JVP. Okay. What is the first? As you can see, these jugular veins, they are what? Extended due to what? This backflow of blood into the what? Jugular vein. So what is that clinical feature that you can see from the patient during an exam? You are going to see what? Jugular venous what? Distension, JVP. Okay, you're going to see that. If you see, the moment you see that, the cause will be what? Right-sided heart failure. But sometimes biventricular heart failure can also cause what? Increase in the jugular venous what? Distension. So apart from that importance that you can see, okay? As you can see, this is what? This is, okay, let's just imagine this is the liver. Now we've just gotten one cell from the liver, which is the hepatocyte. We've just gotten the hepatocyte from the liver, okay? And this is an artery, and this is the vein, and this is the hepatic vein, okay? And this is what maybe the biliary tract like that, okay? Now, if you look at here, since there is increase in the central venous pressure, there is what? Backflow of blood into the what? Into the liver. If there is backflow of blood into the liver, it will start causing what? Congestion into the what? The liver. Okay, it will start causing congestion in the liver. If there is congestion in the liver, there will be what? Hepatocyte damage, leading to what? Important clinical disorder that we know. It is what? Cirrhosis. No wonder sometimes they say right-sided heart failure is one of the important cause of what? Cirrhosis. So what can you see from here? So you can see the clinical disorder that you can see from here, or the complication that can arise due to right-sided heart failure is what? Cirrhosis. Okay. Cirrhosis. Okay. Sometimes you can also see hepatitis like that as well. Okay. You can see a lot of things. Okay. What else apart from there will be hepatic injury leading to what? Cirrhosis. Okay. Sometimes there will be acute hepatitis as well. Okay. Then apart from that, what else? This blood coming from the what? This inferior vena cava like that. It can also go to where? It can also go here. Okay. It can also go here to the what? To the abdomen there. Okay. And start going to the what? In the peritoneal cavity. So this fluid can come and start going the what? Peritoneal cavity there, and causing what? Congestion in the what? Peritoneal cavity, causing a certain what? Clinical feature which we call ascites. Okay, very important. So right-sided heart failure as well is going to what? Cause ascites. Apart from ascites, it can also cause what we call, so this fluid, it can also go to the what? Lower limbs, causing what? Peripheral edema. Okay, peripheral. So it can, so this fluid. This fluid can also go into the what? Lower limb, where to go in the interstitial space of the what? Lower limb, causing what? Peripheral edema. What type of edema is that? It will be what? Pitting edema. Okay. So what are we saying? So the other clinical sign that you can see is what? Peripheral pitting what? Peripheral pitting edema. Peripheral pit edema. A lot of what? Complication and the signs that can arise, signs and symptoms that can arise from what? Right-sided heart failure and also left-sided heart failure. Okay. Now, if we talk about this one, if we talk about, we said congestion. So congestion is done like that. Okay. If we talk about now decrease in perfusion. This can also, decrease in tissue perfusion can also happen with right-sided heart failure. How? But if it is what? If it is very, very severe, like someone experiencing what? ADHF, which is acute decompensated heart failure. If they are experiencing like that, but in what way? Okay? In what way? Remember that if this is the heart like that, okay? If this is the heart like that, okay, if this is the heart, now this is the right side which is fading like that, okay? In due time, if this is fading, it will start what? Dilating. If it is dilating like that, it will start what? Like obstructing the what? The left side like that. If it is obstructing the left side, basically the space within the what? Left ventricles what? Will become what? Smaller. Then if it becomes smaller here, what's going to happen to the cardiac output? Cardiac output will be what? Will be low. And if it is low, basically it's going to cause what? It's going to cause low tissue perfusion, leading to what? The symptoms and signs that we talked about here. Okay, due to what? Due to low tissue perfusion. So it can happen due to what? The septum is going to shift to the what? To the left side, due to what? This right-sided what? Ventricular remodeling, or there will be dilatation of what? Right ventricle, causing what? The septum to shift to the what? Left side. If the septum shift to the left side, it's going to cause what? Decrease in the space of what? The ventricles. There, if there's a little space in the ventricles, it will lead to what? Decrease in the cardiac output. That's how tissue perfusion can what? Arise there. Okay. So basically, those are the complications that you need to understand. If you look at now the high output cardiac failure. So what do we say about that? So this is the last part that we need to talk about. So the high output. So if this is the heart like that, okay, this is the heart. High output cardiac failure. Okay, high output cardiac failure is like this. Okay, so high output cardiac failure. So we are talking about the high output cardiac failure. Okay, high output heart failure or cardiac failure. Then basically this one is not, the problem is not because of the heart. The heart is just okay. There is no reduced contraction. There is no what reduced feeling. But the problem is because of what, this super dilated what blood vessel. So these blood vessels are what super dilated. And what could cause that? What could cause the high output cardiac failure? Okay, the first cause is what, beriberi. So it has been shown that beriberi can cause what, high output what cardiac failure. Okay, what else? Severe anemia. Anemia can cause what, high output what cardiac what failure. And the most and last important aspect that we need to talk about is what, sepsis. Sepsis can cause what? Can cause high output what cardiac failure. So high output cardiac failure, what does it mean? It means that the cardiac output is high, okay, but the heart is failing. Remember that the one that we are talking about the low output cardiac failure, because the cardiac output was what, low, okay, but here it is high. But you might think that that is a good thing where cardiac output is what, high, but the problem is this. Okay, so the problem is this cardiac output, although it is high, so here, although the cardiac output is what, high, although the cardiac output is high, but it is not meeting the what, the body demand. It is not meeting the body demand. Although the cardiac output is high, but it's not meeting the body demand. Remember the formula for what? BP. We said BP is nothing but equal to cardiac output times what? Systemic vascular resistance. Here the problem is not what? It's not the cardiac output. The problem is what? The problem is the systemic vascular resistance. The reason why there is decrease in systemic vascular resistance, because these blood vessels are what? Super dilated. If you dilate the blood vessels, you are going to decrease the what? Systemic vascular resistance. Now, how do the body going to compensate for that? It's going to compensate by what? Increasing the what? The cardiac output. Okay, that's why in what, high output cardiac failure, there is increase in the what, cardiac output, due to what? Compensatory mechanism of the body. Okay, so that's the main reason. Now, what are the complications of this? The complications of this are the same as what? The left-sided heart failure. It can have congestion, it can have decreased tissue perfusion, these same complications that we talked about, and also the signs and symptoms that we talked about. It's going to have the same complication. Just wanted to talk about it so that you understand what happens in high output cardiac failure. Now, let's talk about what? Let's talk about diagnosis and what? Treatment. Now, let's talk about the treatment of congestive heart failure. Okay, so we'll talk about the treatment and also diagnosis of congestive heart failure. Okay, so for diagnosis of congestive heart failure, basically you're going to follow the history, you do the exam, and also investigation, which are very important to take note. Okay, so from history you're going to do a lot of things, So history, you're going to ask about the famous symptoms that we talked about from there, according to from the complications. What is the first thing that we can ask? Ask about what? Orthopnea. We know that. Ask about what? Orthopnea, which is remember that difficulty when it comes to breathing when someone is lying flat. Okay. Also PND. Remember that when someone is asleep, difficulty in breathing. PND, you do that. Okay. What else? Also, if they're having just dyspnea as well, ask about the dyspnea. Okay. Also, the other thing, another important thing, also ask about what? Chest pain. Okay. And there are a lot of things that you can ask from heart history. Okay. Others I'll just tell you. You can also ask about if they are having swelling from both legs, because swelling has to be what? If bilateral. Why? Because there's a certain condition that can just cause what? unilateral legs swelling. So it has to be what? A differential to that. So bilateral swelling, that is for what? Right-sided what? Heart failure. Okay. So you need to ask about the swelling, also ask about the past from the past medical history, ask about the history of hypertension, history of like lung disease like maybe they're having pneumonia, TB, like that. So those are the things that can predispose someone to develop what? Congestive heart failure. Ask about the weight, okay? Ask about the weight, now the symptoms of what? Anemia, okay? Generalized body weakness, appetite. So a lot of stuff that you can ask from what? From history, okay? Now, if you do history, okay, if you do history, then what else you can do? You can also do what? Exam. Exam again, okay, basically is where you can now do a lot of things. You can do, okay, you do first general exam, you look at the general appearance of the patient, mental status, nutritional status, okay, the vitals you do from there, okay, either they're going to have increased blood pressure or maybe low blood pressure depending on the cause of what? The heart failure, okay. So you ask about that as well. So that's about general exam. Also do now you can do the respiratory exam. We can also do what? You can do the cardiovascular exam. So you do cardiovascular what? Exam. So cardiovascular exam, they are very important thing that you can take note. Okay, if you take a stethoscope, then you can hear S3. Okay, S3. So these are S3 gallops. These are what? The classical signs of what? Classic sign of what? Congestive heart failure. Okay, so you can also look at the heartbeat. The heartbeat is going to be displaced. Okay, or the apex beat is going to be displaced like that. Okay. So a lot that you can look at on the cardiovascular exam, a lot. Okay, from the respiratory exam, you are going to notice increased respiratory rate, increase of work of breathing by using what? Accessory muscles. A lot that you can do from what? An exam. Okay. You can also do a GIT exam where you're going to see maybe abdominal distension, bilateral leg swelling. You are going to observe a lot of peripheral edema. Okay. Again, from respiratory exam, you can also, like, you get your stethoscope, you hear on the what? From the lungs, you're going to hear the what? The lung basoclarcos, a lot of things, okay? You can see, you can do from exam, okay? Once the moment you do history and the exam, from everything that I've explained, then you can do what? Investigation. So investigation, you can do blood what? So you can do blood test, okay? So you can do what? Blood test. So you can do blood what? Test, like where you do full blood what? Count. Full blood count, you're just assessing for what? You look for anemia and what? Maybe if there is an infection there. Remember, sepsis was one of the cause of congestive heart failure. So you do also full blood count to observe that. Okay. What else? You can also do from like there are other investigations that you can do, like the liver functional test. Okay. Liver functional test, because the liver was also failing. The renal functional test, they are going to help you. Renal functional test as well. Okay, these are going to what? Help you. Okay, so you can also do a lot of the coagulation profile. Okay, you look at that. You look at for under coagulation profile, you look at the fibrogen level, deep dimers, clotting time, like the PTT time, okay, prothrombin time. You look at that as well, okay. It's going to help you. Then the other important aspect that I need to talk about is what? Imaging. Apart from the blood test and everything, we talk about what? Imaging. So imaging, the very, very important one is what? You know, you're going to do chest X-ray, okay? Chest X-ray. So from chest X-ray, what can you see? So you can do from chest X-ray, you can see like the KLB signs or the KLB line. You can look at the pulmonary effusion. You can look at that cardiomegaly. Okay. You can also look at that. Okay. Pulmonary edema. You can see pulmonary congestion. You can see all those things from what? Chest what? It is very, very helpful when it comes to what? Congestive heart failure. What other important investigation that you can do? You can also do echo. So you can do echocardiograph. Okay. From echo, From echo, it's a very very important diagnostic procedure, where because it's going to tell you the ejection fraction. Remember that if you classify the heart failure, there was heart failure with what reduced ejection fraction, and heart failure with what preserved ejection fraction. Heart failure with the reduced ejection fraction was about what, less than what, 40%. What about heart failure with preserved ejection fraction? We said that was what, 50. But other books they say greater than what, 40%. Okay, so echo is going to tell you that. Okay, and also it's going to tell you about also the size of the heart chambers. Is going to tell you about that as well. So here the very important thing is what is echo. Echo is very very important in just talking about ejection fraction, to help you to differentiate those type of heart failure, the classification that I talked about. Okay, so chest X-ray and echo, these are very very important what diagnostic procedures. Sometimes you can do electrocardiogram. Electrocardiogram is going to help you to like look at the arrhythmias. If the left ventricles are what, hypertrophy, it's going to show you like that. Okay, very very important. Oh my God. Okay, so it's going to help you to do that. Okay, so these are the very important what investigation procedure that you can do, and also the diagnostic approach that you can do. Okay, now let's go to treatment of what, congestive heart failure. So this is the general treatment of what, heart failure. Okay, the first one that we'll talk about is non-pharmacological treatment, and the last one is what, pharmacological treatment. Okay, so under non-pharmacological treatment there is what, lifestyle and supportive measures, and the other one is what, treat the cause and the precipitating factor. For pharmacological treatment, we'll talk about the drugs that improve survival, and the drugs that are going to relieve the what, symptoms. Very very important. Okay, so now let's talk about the first one. So non-pharmacological treatment, the first one is what, lifestyle supportive measures. Remember that for lifestyle supportive measures, you can encourage a patient with congestive heart failure to restrict from drinking a lot of fluid like that. So fluid restriction and what, and what else? Fluid restriction and salt restriction, because those, they're going to make the heart to decompensate like that. Okay, or making the symptoms worse. So make sure that they restrict from fluid and what, and salt as well. Basically, they estimate that about for salt restriction, it has to be at least below 2 grams. For fluid, it has to be what, 1.5 to 2 grams, 2 liters per what, per day. That is for fluid. Okay, then apart from so we are saying here, the first one is what, fluid and what, fluid and salt restriction. Okay, so this is what we are saying. So fluid and salt what, restriction. What else? The other one that we can talk about is what, alcohol and what, smoking cessation, smoking cessation. Okay, you stop smoking, and also alcohol. Okay, so those are the important things that you can do. Also make sure that you monitor the weight per what, every day or per day. Okay, you monitor the weight under lifestyle and supportive what, measures. We go to B, treat the cause and what, the precipitating factor. So you need to control here. You need to control the what, control hypertension that they're having. So you control the hypertension. Okay, you control the hypertension that they're having. Okay, and make sure that you avoid what, avoid drugs like what, NSAIDs, because NSAIDs, they precipitate what, they precipitate congestive heart failure. So that is about what, treatment, treat the cause and what, precipitating what factors. Make sure that you control the hypertension, avoid drugs like what, NSAID. Okay, other causes also you need to you treat them. Okay, the other causes of congestive heart failure, there are a lot. So let's just talk about 2. Okay, then under the most important part, this is just under non-pharmacological treatment. Okay, but the other one, this which is pharmacological treatment, this is the mainstay treatment of what, congestive heart failure. There is what, drug that improves survival, and the drug that are for what, symptom relief. Okay, what are the first drugs that are really recommended? That is what AC inhibitors. Okay, AC inhibitors. So AC inhibitors, okay, AC inhibitors or ARBs, okay, or ARBs, okay, and with ARBs, okay, ARBs, which is angiotensin receptor what blockers. So AC inhibitors, good example what that is what in Arab. Then the good example for ARBs, okay, we can talk about valsartan. Valsartan is a good example of what this. So it has been shown that they improve survival for someone having what congestive heart failure. What else apart from that? We can also add a beta blocker. So let's just put DB beta blocker. Beta blocker like metoprolol or maybe calvidero. So those also they help in the what? In the like improvement of the what survival. But remember that there are some people or patients that do not tolerate what AC inhibitor. You can use what you can replace AC inhibitors with what vasodilators like what hydralazine. Okay. So what else? Also you can add on here the drug that improves survival. You can also add on what we call mineralocorticoid antagonists. Okay. What are we saying? Mineralocorticoid receptor antagonist. Okay, receptor antagonist. Okay, mineralocorticoid receptor antagonist like what spironolactone. Okay, so those it has been shown that they improve survival as well. Okay, and what else? The other important drug that we can use is what ARNI. So ARNI basically that is angiotensin receptor neprilysin inhibitor. This one, it has been shown that it is so powerful or potent than what ARBs. Okay, they show much survival than what ARBs. Very important to take note as well. Okay, so what else? There is also drugs for what symptoms relief. So there are drugs now that are going to relieve what the symptom. What is the first one? The first one is what diuretics. Okay, the first one is what diuretics. What is the first one? Diuretics. So remember that there are different types of diuretics. There are what we call loop diuretics. Okay, loop diuretics like furosemide. There is what we call also third diuretics like what hydrochlorothiazide. There is also what we call potassium sparing what diuretics like. So apart from diuretics, there is also another newer drug that has been developed, that which is SGLT2 receptor antagonist drug. So they are going to antagonize that type of what receptor. Okay, if they antagonize, basically they are going to relieve the symptom of what congestive heart failure. Which one is the last one? The last one is what digoxin. Okay, digoxin is a very important inotropic what drug, and it's going to improve what someone who is having AFib. It's a very important. It has been shown to improve symptoms. Someone having what AFib. Okay, very important point to take note. So basically, this is the diagnosis and treatment of what congestive heart failure. So make sure that you subscribe and don't forget to like the video.